Welcome to the Doctor's Corner with Dr. Kline and Janelle Elgaway. And now, Janelle Elgaway.
Good evening and welcome to the Doctor's Corner on Call 360 Network. I'm your host, Janelle Elgaway, and we are here with Dr. Kline. Welcome, Dr. Kline.
Good to be here, Janelle.
Happy to have you. Tonight we are focusing on the topic of part 2 of how to talk to your doctor, and also we will be going over hospital issues. We will answer a few questions from our mailbag. The mailbag is questions that we were asked in previous shows on YouTube chat that went unanswered, or questions that have people written in. So if you have future mailbag questions, you can send them in to my assistant, Jess Stewart. Her email is jstewart@caw360.com. If anyone would like to call in with a question this evening, you can do so at 415-915-2291. There are 2 ways to listen into tonight's program: through our website, which is www.cawnation, or YouTube channel, The Doctor's Corner. So, Dr. Kline, is there anything newsworthy that occurred in the last week that you'd like to share with us?
Yes, a very important piece of science has come out of the Massachusetts General Hospital in Boston, their research division. MGH has the largest medical research division in the country. And what they did is they paired up some studies and people from overseas, and they used a special kind of MRI called a PET scan, P-E-T scan. And lo and behold, people with fibromyalgia have huge amounts of brain inflammation. So for the very first time, it means this is a real disease. It is not a fake disease, and it is basically a low-grade inflammation of the brain. Now, when you have inflammation of the brain, it screws up a lot of things. One is the sympathetic nervous system. Patients have sudden elevations in their blood pressure. They have wide pupils. Hearts will race for no reason. That's the sympathetic nervous system. They'll develop pain for no reason. They have tiredness from the inflammation. So we're going to call this a new disease systemic inflammatory disease, because it's probably not just in the brain, it's probably all over. Now, this would include the old diseases of fibromyalgia and what's the other one? See, I don't pay any attention to them. So chronic fatigue syndrome. So chronic fatigue syndrome and fibromyalgia are probably the same disease, and they're caused by a generalized inflammation that then in turn screws up the ability to sense and respond to pain. So it's very much like central regional pain syndrome. In the same thing is going on. The inflammation is interfering with the body's ability to properly read the pain. For example, I saw a patient today that flew in on an airplane, and she said it was just miserable sitting there on the airplane. Nothing wrong with her back, nothing wrong with her SI joints. Why was that? Well, if anybody's been on an airplane jammed in like sardines, pretty soon your rear end starts to hurt and you start trying to move around. Well, if you've got a disease, inflammatory disease, that's misperceiving the pain, then the normal pain of sitting in a seat becomes enormous. And so, the best flight she said she ever has when she was able to lie down on a seat. So this explains a lot. If your brain has a low-grade inflammation, you're going to have a hard time with a lot of things. But in her case, low-dose Vicodin did the trick. Just did the trick. And over the past 10 years or so, she's only had 2 years that she was treated successfully with the Vicodin. Then they took her off. So after 2 years of her life coming back together, as everybody who has these god-awful diseases knows, it ruins your life. So a little bit of safe medicine, and of course she had had it before, so she wouldn't addict, and she had low dose, she would never overdose. A little bit of medicine changed her life, and then she went for a year without it. That's a terrible story, but now there's proof. Now the study from the Mass General, they can just make copies of it, and maybe we can put it on your website or something where they can find it. You could just send it to your doctor in the mail. Remember that? Don't take it in on the appointment. Send it in the mail. Doctor, I'd like to share this with you. And it's really catching a lot of news. It's on most of the news networks. It was released at the beginning of October, but it's hitting a lot of the news and blogs and stuff in the Fibromyalgia Foundation. So I advise people not to use the word fibromyalgia or chronic fatigue syndrome. Well, let's just label it systemic inflammatory disease. And the doctor will say, what's that? Say, well, this is this thing that shows up on the brain scan. They used to call it fibromyalgia. We're not calling it that anymore because that's not an accurate description, because there's a lot more to it than fibromyalgia, as people know who have other chronic diseases. I'm beginning to think that all of the diseases have to do with systemic inflammation. So that's the news out of Woebegone.
Yeah. Inflammation plays such a big part in, I think, a lot of health issues. I've dealt with health issues for 24 years, palliative issues, and one thing I've noticed is that if I can keep my inflammation under control, especially when I changed my diet, it really helped if I could keep my inflammation low. What are ways to keep your inflammation low besides the diet? I mean, and besides medication, is there anything else? Or is there
when I met this person in the lobby of the place she was staying overnight before she went back home, her dad and I and she were standing in the lobby, and they had one of these really cool displays with bubbles coming up and, just an art object and different colors. And you know what? I just stood there for a few minutes and zenned out. Z-E-N-E-D, zenned out. And, they have all this mindfulness training and everything, but you can do it at home. You can get candles. You can buy things on Amazon, little bubblers or whatever. And you just stare at them. You turn off the light and stare at them. Some people have little fish tanks and they watch the fish. So, doing a little mindfulness can help a little, once you've got the rest of it under control. Those things are not going to work in themselves. But if you get things under control when you're having a little pain that your pain medicine's not covering, you can try that. And you can try diet, and you can try CPT oils and all those other things. But first, you try a maximal amount of pain medicine, because it's starting to look like pain medicines might also have anti-inflammatory properties. So,
Oh, really?
Oh, yeah. That's because there are pain receptors not only in your brain and on peripheral nerves, but they're inside inflammatory tissue. There are pain receptors in inflammatory tissue. I mean, this is just something I think I mentioned before. I learned 3 or 4 weeks ago, and I'm tracking it down to verify it. But you know what? It kind of makes sense. Because if the inflammation is causing the pain, you really need to take care of the inflammation first.
Right.
And
our bodies also make natural morphine, doesn't it?
They do, absolutely. As a matter of fact, your brain actually makes the chemical morphine, which just blew me away. The same stuff, well, it's not quite the same stuff, oozes out of the plant. Yeah, oozes out of the plant.
That's so major. Wow. All right. Well, I wanted to get to a few mailbag questions, if that's okay.
Sure.
That we had from the past few weeks. So somebody wanted to know, can a gangrenous gallbladder that caused severe pancreatitis cause a person to get diabetes?
No. Simple answer. No, because the pancreas has little cells that make insulin, but they are totally independent from the pancreas. It's just like they're on there for a ride. So, no.
How much is a safe amount of steroids daily?
They think that around 10 milligrams a day for a long period of time is close to what your body makes. But even then, at low dose, there are some side effects of long-term steroids. They're just not as bad. So between 5 and 10 is what your body makes. So you want to provide a little bit more than your body makes. So somewhere in that zone, 5 to 10. But it's still not perfectly safe. But it's acceptable if you have a steroid-sensitive disease, just like painful disease is opiate sensitive. So if you have sensitive diseases, then you use the medicine that works. And if you need the steroids, it's much better to take 7 milligrams a day than it is 40.
Where can I find the USC that states a signature is required for forced taper?
That I don't know. Nobody has recommended forced taperings except 2 people. Andrew Kolodny, president of the Physicians for Responsible Opioid Prescribing, and Dr. Lemke, L-A-M or L-A-M-K-E, I think at Stanford, has made a public statement that people should be forced off their drugs. This is something that I vigorously oppose. Doctors are not in the position of forcing anyone to do anything. Period. So
why does my family's addictive history dictate what I might do? Sorry.
Say again.
Why does my family's addictive history dictate what I might do?
If your family has addiction, you may have addiction, but you also may not. It's the type of genetics that's called incomplete penetrance. So, for example, if you've got 2 diabetic parents, you've got a 60% chance of having diabetes, but 60% is not 100%. So it's the same thing with histories of addiction. You have to be careful the very first time you take an opiate or the very first time you have alcohol. And if nothing happens and you don't go on the magic carpet ride to the moon, you're okay.
Okay, very good. So I wanted to get into tonight's topic a little bit on how to talk to your doctor and also hospital issues. Can you discuss issues with patients at the hospital? Like, what are the current problems patients face when going to the hospital?
Well, it's the same old problem of you don't need pain medicine. That people can be in agony, from having a kidney stone. I remember in medical school, I was told by the emergency room doctors that were teaching us that renal colic, or the pain that comes with a renal stone, is probably one of the most painful things you'll ever see in the emergency room. And I've always remembered that. And so now when they come into the emergency room, well, we want some Tylenol. How about a back rub? And here these people are in agony. So, what I'm suggesting to people who already are taking pain medicines is to try to find your range of pain medicine. You can slowly increase it. If you don't get drowsy, you're doing fine. And then you can try to treat your kidney stone, if you're having trouble in the emergency room, with oral medications. And you can do it if you take enough. But, if you're on pain medicines, you need to talk to your pain doctor and say, look, how high can I go on this? The FDA says you can go to any dose you want as long as you don't get drowsy and nod off and then be in danger of an overdose. And if you've been taking it, you already don't have to worry about addiction. We know that. If you're on the medicines, you'll never, ever become addicted, no matter how much you take or what you take. So I think it's possible for people to try to abort going to the hospital where they're just going to accuse them of being dopers and see if you can handle it. If you can't handle it, with your own pain medicines, then you got to go to the emergency room. But if you take enough oral pain medicine, And safely would be taking enough that you're not getting drowsy or nodding off, or vomiting. Most opiates are limited in dose by vomiting. Then you can give it a try. I have some patients who, kind of roll along at, say, 30 milligrams of oxycodone every 4 hours. But I had one patient that was post-operative, had a back surgery, and usually on the third day, the inflammation from surgery is the worst. So sure enough, on the night of the third day, it was horrible. And they had given him some Mickey Mouse prescription. It wouldn't be enough for an ant. And so we just slowly increased, do it on the phone and texting. And he went from 30 to 90 milligrams without any problem whatsoever. He didn't get drowsy, but it took care of this terrible post-operative pain. I mean, there's nothing worse than being post-op, but it's really bad if they've been munching around with your bones. That is really inexcusable. But so the point is that you're going to run into trouble in the hospital. And one of the things that a couple people have tried, it's sort of the secret weapon. Every hospital has an administrator on call 24 hours a day.
So and what do they do?
What they do is they can overrule the doctors because the doctors work for them. So here's what, in both of these cases, the spouse called up, told the nurse to get the administrator down there right away. Down comes the administrator. And then they just tell the story of the administrator, and the doctor was standing there, and the doctor said, okay, I'll give her more. This was a woman who was post-op cesarean section, great big, huge incision, I mean, I used to go to those, when I was a pediatrician. And I mean, these are big incisions because they don't want the baby getting trapped. So, I mean, the amount of pain you have afterwards is pretty enormous. And they were giving her like one Vicodin or something. She was like way under. So sure enough, calling the administrator was a good trick. And, you stand there like adults, discussing the issue with the boss and the doctor and the patient. And sure enough, they resolved it without a lot of hooting and screaming and yelling. And, the administrator, yeah.
How dangerous is it if you don't treat that pain? I mean...
Well, the big danger that nobody talks about is whether or not you can get central pain syndromes later. It's funny, when you talk to people that have the various inflammatory / painful diseases, they usually always start with something. Woman I saw today, she was a teenager. She had some horrible encephalitis-like virus, 105 temperature, barely could move around in bed, took her a week to get over it. And then her chronic systemic inflammatory disease got started. And you know what? It kind of makes sense in a way. Here you are, your body is battling a brain infection from a virus, and something goes wrong. The inflammation is not shut off. You see, in our bodies, we have these servo mechanisms where if something starts, there's a mechanism to stop it. And so if something goes wrong to these stopping mechanisms, you got a problem. They think that's what goes wrong with cancer, that the cancer should have shut down, but it didn't. I think a lot of these systemic inflammatory diseases, same problem. Something gets it started, and then it just goes haywire, and it kind of reprograms itself to be a super inflammation fighter, because inflammation is a fighter. It fights off things. But somehow it gets out of hand, and it becomes too aggressive. And it's like, too many troops in the battle. Too many is not good as a few. So
we have a caller, if you don't mind, if we take
Sure.
Caller from area code 401. What is your name and what's your question for Dr. Kline?
Hey, Janelle. Hi, Dr. Kline. It's Claudia Morandi calling in. How are you?
Hi, Claudia. Good.
Fine.
How are you?
So, I wanted to call in because I get, as an advocate, my biggest demand to advocate is always in the hospital setting. And As a person who suffered with Crohn's, kidney stones, you name it, I've hit the pain levels on many different occasions. So I've been there. I feel these people's pain, no pun intended. So when I advocate, or when I go in person to advocate for a person in a hospital setting, I always try to keep the family calm. And if it's during the day and I'm not getting anywhere with an emergency room doctor to get a person's pain under control, I always call in risk management at just to start. And once risk management is in the room, then I get the head of the ED in there. And there's usually an administrator floating around, as Dr. Kline has mentioned. And usually once we have that dialogue underway and people are calm, we're all usually successful in getting the person comfortable, but it's trying to keep people at peace, not attacking one another, because that's when we really run into issues. And these doctors look at these poor patients like suspects, the interrogation. And some doctors just, they're standing by, they're like, no, absolutely not. I'm not giving them anything more. This is what I'm giving them. But I want to say 9 times out of 10, when I get risk management in the room, when I get the chief ER doc in there, sometimes I have to call in the chief of hospitalists if I really, need some help. But it's usually the most effective way to find a patient the best, the solution. And the phone calls that I receive, sometimes I receive hourly phone calls to advocate for people in the hospital. I no longer advocate over the phone. I'm just trying to help people to advocate the best way they possibly can. But I always say it, calm heads prevail, because doctors feel threatened, patients feel threatened. So I always encourage people, everybody just really needs to keep their cool. These doctors feel pressure. The patient is howling in pain, because I've been that person howling in pain, but I always had somebody with me to advocate. So that's why I was calling in.
So Miss Diplomat here, so Miss Diplomat and Statesman, this is exactly right. When people become defensive, they tend to dig their heels in, and you get nowhere.
Yeah.
So diplomacy really works, and it's basically like you're saying, look, we got 2 different opinions here. Another thing I find useful is don't tell the doctor what to do. Use pregnant pauses. Doctor, the dilaudid you gave me helped a little bit. I would say I'm about 40%. And then pregnant pause. Don't say anything.
Right.
Let the physician offer the solution. Okay, well, why don't we try a little more dilaudid? How about we go up here and get everybody nodding their heads, and so everybody is save face, which you're obviously doing already. But it's a good Asian trick, from not losing faces is an important thing. And the Asians are particularly sensitive to not losing face. I mean, that's kind of like a fate worse than death. And it's true for everybody, really. You don't want to be caught where the administrator's saying, all right, doctor, you give them the dilaudid or else. You don't want that to happen. You want people. So it sounds like you're doing a wonderful job. And it's good news for people in the hospital to know if you just go up the ladder a little, the chief of the emergency room, director of nursing, administrator on call, blah, blah, blah. So, yeah, that's wonderful that you're doing that. That's great. We should have you be the next UN ambassador. There's an opening.
No, that won't happen. But, I tell patients, I never, recently when my mom, she broke her back, she fell down the stairs, and the doctor said, well, what should I do? I said, well, I didn't go to medical school. You did. And this is why I'm in the hospital. And this is why I'm looking to you. So you tell me what you think is the resolution.
Perfect.
But, it's always trial and error. And then sometimes you just get doctors that they're unreasonable and they're not going to budge. And there's, I have those, I have 20% of the time. you do the best that you can, and you hate to leave a patient suffering. It's the post-op situations that really cause me the most angst, because usually, the patient post-op is the most uncomfortable patient, the patient in the most pain. And what happens is the surgeon performs the surgery, he leaves, and he leaves his intern to take over orders.
Right.
And you've got the interns that are fearful. And that's when I have to get on the phone with the surgeon, track down the surgeon. Okay, who let the ball drop? Why is this person suffering? Is this person going to have a heart attack?
Right.
And that's really when you have to get, all decks, all people on the same page, because that's when those scary situations come into play. But I always go back to cool. I lost my cool not too long ago for a woman who just came out of a horrible bowel resection. And it was just a young intern. And I said, you're going to kill this patient. This person is going to be dead if you do not get some orders put in. So when I advocate, I don't leave until I see those orders. Recently going through what I went through my mom, I said, I don't want any intern getting crafty at midnight with my mother's orders. The orders are the orders until I come in the next day, because of her age. And it worked out well, but it doesn't always work out well. But people can still try and advocate for themselves. So that's why I wanted to call in and say hello to both of you.
Yeah, another thing I thought of.
Take care.
Yeah, go ahead. Another thing I thought of while you were talking is, if you get a physician who's really digging their heels in, just politely say, Doctor, is there someone else that we can get into this discussion for a second opinion? You see, the word second opinion is an accepted doctor term. And anybody who asks for a second opinion usually doesn't get insulted, or at least they shouldn't. So, Doctor, is there somebody else that we could join us for a second opinion? That can work, and it's considered nice. It's not considered terribly aggressive. And the other trick is everybody should have a family member advocate with them in the hospital. You can designate a not power of attorney, but what am I thinking of? The lower grade one that speaks for you. All right, everybody, let's see. We can think of it. Meanwhile, I'll mention that the power of attorney, you got to go to a lawyer and blah, blah, blah. But advocate, patient advocate, what are they called?
Yeah, patient advocate.
Yeah. Anyway, you can just get a form down there at the drugstore or a stationery store and sign and appoint somebody as your advocate. Let's keep working on the term here. Appoint you as an advocate, and then you can say, look,
they're called patient representatives.
Okay, patient representative. And you just sign the paper. You don't need a lawyer. You just sign the paper, and now your mother, your brother, your friend now becomes your patient advocate, and that way you get a little more power. If you flip out this thing and say, look, I'm the patient's advocate and I've been appointed by them. And they'll listen to that. And they frequently get it confused with power of attorney, which is their problem, not mine, that they get the two mixed up. Legally, a power of attorney is the person who can make legal decisions. But if you just have a patient advocate set up and you bring the paper with you and they put it in the chart, and then you can just, ask any questions you want. And you can say, can I speak with the doctor? I'm the patient advocate for my mother, Mrs. Jones, or whatever. So that's also a good technique. And it's accepted in hospitals that patient advocates are, part of the deal.
Well, thank you, Claudia, for calling in. We're going to go on to the next caller. Caller, what's your name and what's your question for Dr. Kline?
Hi, Dr. Kline. Hi, Janelle. It's Julie in New York City.
Hello.
Hi. My GP, I had horrible pain all weekend long, lower abdominal pain. Couldn't take it. Normally, I can take anything. I couldn't take it anymore. GP's out of town, So I had to go to the walk-in clinic. And I just was thinking of Dr. Kline, especially the show last week, How to Talk to the Doctor, because I thought for sure they're going to look at me as a drug addict, or I was very nervous about it. And they didn't. They didn't give me anything for the pain, but this doctor came in very fit, and he started to go over all the narcotics I take. Like, why do I take it? And instead of going into details of every, like apologies, I just said, sarcoidosis is a miserable disease for every single narcotic, the low dose that I take. And by the third one, he just smiled and stopped asking me. So I don't know if that will help people, but I didn't get any more accusatory looks, and they gave me Cipro. I have to follow up. They still don't know what's wrong with me. It could be, they said ruptured cyst, something happened. But I have to follow up, but right now I'm taking ciprofloxacin for the next week, which is
yeah, and you see, you brought up a good point, which is always mention your disease. Don't say I got chronic pain. That just doesn't get you anywhere. You say, well, doctor, my sarcoidosis, as you know, is a very, very painful disease because of the joint involvement. And I do have opiate-sensitive disease, which means the opiates are effective. Because
I'm
we
not
say
even
that.
taking an opiate, though. That's the thing.
You're not taking pain meds?
Well, tramadol.
Okay.
According to the DEA, it's an opiate. That's all we're allowed in New York City. That's the problem. We're not allowed.
Well, just say, and I said in a Twitter, and see, and I'm violating it myself, it's better just to say pain medicine. That covers everything. I'm taking these pain medicines.
It was a neural stimulant, a benzodiazepine, and tramadol. By the time he got to tramadol, I just repeated, and he just smiled, and he's like, okay, like he got it. And he didn't talk about tapering or anything else. And they took me seriously, and they did blood work. After that, he's like, we're going to order blood. And they did, all the tests. They went, they believed me, and they gave me ciprofloxacin. I still have to do a follow-up, but I didn't get thrown out or dismissed.
Diplomacy, yeah, it's diplomacy. It's a good skill to have in all of life. Diplomacy. It's how to.
I made him laugh.
Good, and that's another thing is humor does work. One person wrote in and said, I go right into the doctor's office and I say to him, I really am a dope fiend. And tried to make a little joke, and the doctor laughed, and the humorless doctor actually laughed, and so humor and being nice but firm. See, that's the trick. Yeah. When you're a diplomat, you're nice to somebody, but you're still being firm. You're presenting your position. So that was a good example of that, and it worked nicely for you. Thanks.
I just repeated the same thing. By the third time, he just smiled and stopped with the accusation.
There you go.
We went right, he went right into the exam and took me seriously. It helped. I thought of you. And my father's having trouble. They promised him tramadol. They denied it. So we're going to do the letter writing, as you suggested last week.
Yep.
It's getting bad in New York City, just to let you know.
It's bad everywhere. It's awful.
Everywhere. Oh, I know.
And tramadol is kind of my last choice for a drug. And
is that really an opiate?
Not even allowed here anymore.
It's technically not an opiate. It's the only drug FDA puts a maximum dose on.
Why is that?
Because it's got a lot of systemic side effects. It's weird,
It's
and
SRSI as well. That's
okay. So it's like half of an antidepressant stuff.
It actually, it depends. It's such a weird drug because in some people it's nothing. For other people it works. But the DEA is the one that said it worked. It's just as bad as an OxyContin. They're the ones, not the FDA. It was the DEA. And actually Merck, it said, I looked at the Oregon pain prescription guidance said that they're following the DEA's instructions, not
Well.
the FDA.
DEA
You should
instructions.
read it, the 72-page of true crime horror. Which was adopted to the CDC. The same writers wrote the new 992-page CDC prescription guidelines. Same thing. They follow the DEA's medical advice, because they're medical geniuses.
Well, they
Not
just.
the FDA.
Well, thanks for that example. That's a good example of diplomacy, and it does work. Thanks.
Thank you.
Thank you
for
calling.
helping us.
Yep.
Have a good day. Have a good night. Thank you, Janelle.
All right.
Bye-bye. Thank you,
Yep.
Dr. Kline. Okay.
Bye-bye. So let me ask you something. So say if I break my arm and I need to go to the hospital, and I'm already a palliative care patient, or I have chronic issues. When I go in, and are they going to give me problems with receiving any medication if I'm already on pain medication?
Yeah.
And what do we do at that point? I mean, are we supposed to be on more? How is that really? What does our bodies really need at that moment? Actually?
Yeah, you need more. In other words, you need to say, I'm on pain medicine for my painful disease, and then always say what it is. I'm on my painful disease, rheumatoid arthritis, on a maintenance dose. See, that's a doctor word, maintenance dose, which usually means low dose. So I'm on a maintenance dose, but I'm not taking enough to cover broken arms, or my broken leg. And don't say things like, I need more, just do the pregnant pause and wait for the doctors to make the suggestion. You just say, this is my maintenance medicine. It's not intended to be enough for broken arms, or trauma. And then just don't say anything.
Does it actually cover it, our bodies? Because I always, it feels like there's more pain suddenly. Is there? I mean, and the medicine, the pain medicine that we're currently on, does that really cover it, though? I mean, scientifically.
Yes, it does. And, opiates work very well if you take enough. And even though I just read some humorous thing today from the Michigan Medical Society, safe prescribing. This is the latest thing. Safe prescribing of opiates.
And what does that mean?
And of course, that assumes we've been prescribing them unsafely. So when you read it, it's really just either not prescribing or prescribing these ridiculously low doses. So safe prescribing of opiates, they believe, is either no dose or low dose. And guess what? That's not true. Safe prescribing of any drug is to give it and monitor for side effects. You're giving it according to the FDA's rules, and that's safe prescribing. If I give you an antibiotic and it says you're supposed to get 200 milligrams every 6 hours, safe prescribing is giving it appropriately. Unsafe prescribing would be, doubling it for no reason, or giving half. So really, unsafe prescribing is giving not enough, but that's not what people believe. Safe prescribing is kind of like the word cleaning. There's nothing better than the word cleaning. Bring somebody into the house for a cleaning. Oh, let's go to the dentist for a cleaning. We just love to be clean. And so by using the word safe, it's like the word clean. Everybody just assumes the word safe is wonderful. Is it safe, for example, to police patrolling your neighborhoods? Of course. Is it safe if the police go around snooping around your barbecue looking for drunks? They can claim that's safe, but it's not. So you really have to ask the next question. Safe prescribing. Oh, what is that? What do you mean by safe prescribing? Oh, you don't give too much. Has there been a problem with people giving too much? Oh, yes. If you give too much, you'll become addicted. Oh, I heard that wasn't true. Oh, we think it's true. Well, show me the evidence of that, because there are a lot of people that don't think that's true. So let's go back to what else do you consider safe prescribing? It's really insulting to us doctors to have a police department or people at the infectious disease agency telling me, or the DEA telling me I am not prescribing safely. I'm an idiot. And here I'm causing all this harm and causing all these addicts to die because I've given a patient too much medicine. Whoa, let's back up here and ask a few questions. Do you mind if we ask questions? Oh, you mind? Oh, I see. Yeah. I mean, if people are not going to answer your questions, then you got to say, well, look, I got to go get a donut.
Right. Well, and if you think about it too, I mean, when somebody's in the hospital, I don't think they're going to be able to sit there and think, oh, can I ask all these questions? It's hard. That's why it's so important to have a patient advocate, like Claudia said, or it's so important. Do they have programs like that for people? I mean, at a hospital, besides the administration of the hospital?
Programs like what? Like patient advocate.
Yeah.
They really should. You see, hospitals are closed shops. They're really not good places for sick people. And if hospitals really did want to connect with the community, they would have those kinds of things. How do you advocate when you have a problem? And if hospitals did that, they would get a lot better ratings. The Mass General in Boston, which is, a world famous hospital, only got a 70% good rating from their patients. So, as great as they are, they need to do some work with the community, and they need to ask people who've been there as patients, hey, what can we do? They pay lip service to that. They don't really want to do it. They want to stay up there in their corner offices and negotiate, contracts and increase profits. But obviously, any business that respects its customers is going to do better. So I think that's a great idea. They should have how to be a patient advocate as part of the hospital. Come in for the Saturday session. We'll teach you how to be an advocate. Can you imagine a hospital doing that?
Well, and I was wondering too. Yeah, no, absolutely. Should they have a something if there is palliative care or intractable pain patients? Should they have a separate section, for the ER for somebody like us?
Well, they certainly should be. Yeah, I think if everybody had a little card, a little plasticized card that says I'm a palliative care patient, I am protected against.
I mean, they're already targeting us anyway with
and
throwing together with addicts. So, I mean, why not have something so that there's a procedure, protocol of how to.
There should be. Right. Everybody loves protocols, so there ought to be one hanging up in the emergency room.
Exactly.
What to do if your patient's on palliative care. But first we got to work on this definition. It's just amazing how physicians are just, I wrote that little thing on Medium, but, a lot of doctors don't read that. So, we need to work on getting the word out. It's a simple thing. And on Medium, all you got to do is Google Medium palliative care Kline, and you can get it directly. And get the little article and make a copy of it and send it to your doctor in the mail. Don't take it with you. In the mail. Dear doctor, saw this on the internet. What do you think? And then let the doctor make the decision. Don't try to make decisions for physicians. It's okay if they say, well, what's worked in the past? Well, oxycodone and Vicodin work real well, but don't say it initially. Don't say, look, doctor, this Vicodin really worked well and I want some more of it.
Right, exactly.
Okay.
I wanted to remind our audience really quickly, if you'd like to call in with a question for Dr. Kline, you can do so at 415-915-2291. And somebody from YouTube says, Ms. Harris says, you can get the Medium app. So there's an app, I guess. For
really?
Medium.
Oh.
I didn't know that either. Thank you for letting us know. So let me ask you more about hospitals, because I have a ton of questions too. What are we facing right now as a patient, and of what's the current care and where we're going? If for the hospital and for just primary cares, I mean, is there a difference?
Well, hospitals really need to kind of hit the refresh button Doctors need to hit the refresh button, and they need to come to the conclusion that we need medical care 2.0. Things have to change. The typical hospital can make lots of money and still be consumer friendly. Now, they always talk about being consumer friendly, but they are not. Doctors' offices are not consumer friendly. I just talked to a guy today. He said just to get his lisinopril prescription for his blood pressure refilled, he had to make 4 phone calls to the office. So what's the problem there? That's 1.0. That's not 2.0 medicine. 2.0 medicine is training people. The best patients, the best people to work in an office are ex-patients, people who've had illness. And my God, if you can't be compassionate in a doctor's office, where can you be compassionate? I find there's more compassion down at the McDonald's. Oh, here's your hamburger. Is it okay? And bring it back if there's a problem. And here's some mustard. You don't find that in a doctor's office, and you don't find that in hospitals. I think the secret to hospital care are nurses. Nurses really are the ones that have the compassion. And what they do is they take good nurses and they turn them into managers and put them on bonuses. And then they say, well, go down there and cut care. It's the line nurses, and, a lot of places they've unionized, which I think is real good idea, because when the administrators come down and the chief nurse comes down and tells them not to do things because it's too expensive, they say, well, we're going to do it anyway. And you got a problem, you talk to my union rep. Nurses really need to be empowered more. Most of the nurses I've dealt with are as bright as doctors, and they seem to know more what's really going on. Doctors are really consultants. We're kind of in the consultant role. And then other people should agree or disagree with us, add to the decision, or subtract from the decision, and then carry out the process. Somebody said once that doctors don't do any medical care. It's the nurses and the nurses' aides that do the medical care. We don't do anything. We just write prescriptions and send people off for x-rays, but we don't really do anything. Surgeons say they do things, but, I've had plenty of surgical techs say that they could do these operations anyway. All it needs is good eye-hand coordination.
What's the difference between a nurse practitioner and just a nurse?
A nurse goes and gets a BS, gets a graduate degree in nursing school and graduates. Now, if you want to be a nurse practitioner, you go 2 more years to a nurse practitioner program where you get a master's degree. And during that time, you learn it's more intensive training. So the nurse, who probably knows a lot of the stuff anyway, spends more time learning to do physical diagnosis. I remember I was in the hospital once, a nurse came in and listened to my lungs and my heart. I thought, whoa, that's great. Medical school is see one, do one, teach one. Nurses can do anything, really. They could do operations. And the doctors, because they're trained more, need to be the commanders, and make the tough decisions and provide a direction. It's like the captain of a ship. Captain of a ship doesn't drive the ship, sits down in the stateroom reading books. But there's 2 times the captains always come on deck. 1, when the ship is changing direction, and 2, when there's a problem. And that's the way it's been for captains for 500 years. So it's the same model with doctors. You come when there's a problem, you help make the diagnosis, which only doctors can do, by the way. Doctors need to make diagnoses, and you have to have a license to do that, such as the diagnosis of palliative care. That can only be made by a doctor or a nurse practitioner or PA, licensed medical person. So I think we need to empower nurses. I think we need to give more empowerment to nurses' aides. When I was working in a nursing home doing consults for a severe wound and wound care, I found the nurses' aides knew more of what was going on than anybody. And they should be part of the process. In China, it used to be that when doctors came and made rounds, they made rounds with everybody in the hospital. Patients, janitors, it didn't matter. Everybody went around together. And somebody would say, well, I saw Mr. Yee last night. He was having trouble in the bathroom. Oh, really? So kind of like, the more people on putting on hands. But I found nurses' aides really have critical insights into people, especially with long-term illness, and will tell the nurse or the doctor things if asked, that really make a big difference in care. But nurses' aides are just there to clean up. And the ones that I worked with were a lot more than that. So empowering nurses' aides, there's really only a couple of people that take care of patients, nurses' aides, nurses, and sometimes doctors, but not very often. So you need to empower the people that actually provide care.
Are nurses almost like the gatekeeper, kind of? I mean...
Yeah, they are. They're, I hate to say this, but it's a typical woman's role, which they need to get out of because they're bright and they're good managers. And it's like a good friend of mine was the secretary, for the superintendent of schools in a school district, but she ran the district. She was the brains behind the district. She ran the district. And the superintendent just went around smiling and going to football games. It's the same thing, and we're kind of finally learning that women can do anything boys can do. And there's nothing wrong with women who are nurses' aides participating as, full members of the team. And I hate to say it, but, in hospitals, there's still that division. It's being broken down more, but it's still bad with nurses' aides because 90% are women. Yeah.
I spoke with one of the major doctors here at Raleigh, at one of the hospitals. He was saying that the majority of people that come into the ER are overdoses. And what do you agree with that? And why are we paying attention more to it now, and that's why it seems like there is, or are there really more overdoses in the hospital? And is it,
I don't have any data on that, but I did kind of look at some of the data, and here's the problem. The computers don't deal with overdose. The computers deal with numbers. So somebody comes into the emergency room and they're required to code the visit. So they code it as a X51.3. So that may be heroin. Or is it coded 49.8? So then they take those numbers and then they make decisions. Wrong. You want to do a study that says there's more overdoses in the emergency room, you have to pull each chart and read it and code it. Because what happens is people come to the emergency room, I'm in pain, doctor. For God's sake, my doctor doesn't give me enough pain medicine. Must be, let's see, what code would that be? Oh, there is no code for under treatment. Now let me just look over these other codes here. Oh, well, I don't know. It kind of fits with overdose, I guess. It's a narcotic problem, so I'll just code it X51. And, we doctors don't give a hoot about these codes, so we just pick one so we can move on to the next patient. But we're forced to sit there and come up with these code numbers that they can use in the computers in Social Security, where they think they can cure all illness by doing surveys and data analysis, and they don't realize that we don't put in the right data. When I'm coding diagnosis codes, I just do the closest one. So unless you read the study and it says we have reviewed the charts, forget it. And so anybody that says this or that, increase this or increase that, don't believe it. They're not doing proper science. So my guess is there's probably not more overdoses because overdoses are pretty much only in the addiction community. And unless you suddenly get more addicts in the area, it's going to stay about the same. It's about 2% of addicts die each year, which is really too bad. That's 1 in 50 people because they're not getting medical care. But it's the overdose. It's the fear of addiction phobia. They're sitting down there in the emergency room.
Normal. It's just, it just seems like it to them.
It's just more. And then, of course, the media picks it up. More overdoses as those doctors prescribing too much opiates. I knew it all along.
Yep. Just from YouTube asks, is there a place to view a hospital statistics like that without revealing HIPAA info is available to the public?
Most all of it is not HIPAA guarded because it's done without names. So in other words, you can view the hospital statistics. When they say that they had 100 people with heart disease and 2 of them died, I mean those are all done without names. So those are okay to look at. Yeah.
Do you think palliative care patients, if they should have, do you believe that they should have a card or something, and if they should be treated differently? Somebody wants to know.
Yes, I do think they should have a card. And the main thing that palliative care protects you from is fooling around with your dose of medicine. Palliative care exempts rules about dose restriction. In this state, in North Carolina, we only have one restriction. That is, you can't give a prescription for more than 7 days or something, which, of course, is silly. But if you're palliative care, then that does not apply. So you could say, well, doctor, maybe I need a 10-day prescription. Or if there's dose restrictions, the CDC guidelines, the voluntary, non-mandated guidelines, start off the very first sentence, and it says, people with palliative care are exempted from the CDC guidelines. So if somebody says, 90 milligrams is all you can have, and you can say, where'd you get that? Oh, from the CDC. Are you aware of the fact that I am a palliative care patient, and on the first sentence of the CDC guidelines, it says I'm exempted? But again, so you're getting into the battle with the doctor, so it's better to bring that in ahead of time. You can go online and just put in March 15th, 2016, CDC guidelines, and make a copy of the very first page and highlight it where it says palliative care is accepted. And then say, I'm a palliative care patient. And if you want to give them the diagnosis code, it is Z as in zebra, 51.5.
51.I.
That's the palliative care. There's a number and a letter for all diagnoses. 100,000 of them.
Wow. Okay. All right. I'm putting that out to everybody on YouTube. So we are going to wrap up here, but is there anything that you wanted to tell us before we end here about hospitals or how to talk to doctors?
Well, in the hospitals, you have allies because you can ask for administrators, director of nursing, director of the emergency room. Always just go up the ladder one person. And that can be a big help. Offices, you're stuck. However, if you've got offices that are part of a chain, like a hospital chain, then you can do the same thing. You can call the hospital administrator and say, who's in charge of this clinic? In other words, you're exhausting administrative remedies. If you've got a small clinic, they are licensed by the state. Look them up, see who the boss is, see who the owner is, and then you contact the owner. And remember, send your complaints in ahead of time. Don't do it face-to-face. Send in little reports. Doctor, I was humiliated by Dr. So-and-so who refused to prescribe me enough blah, blah, even though FDA says it's okay, just real polite, and sends things in behind the scenes. Because once somebody gets a piece of paper, they feel like they got to do something with it. They can't just throw it away, so it worries them. So letters, very helpful in a diplomatic way, as we've been talking. Understand that physicians are under the gun, and maybe some of them are ignorant of the facts, as I used to be, and so you want to gently try to bring them around. And the good news about fibromyalgia, the new term we're going to use is systemic inflammatory disease, and it's a real disease and shows up on MRIs, special MRIs.
Oh, that's wonderful. We have one quick question from Stephen Hicks on YouTube. Do you know whether or not Oregon has a law protecting palliative care?
Yes, they do.
Yes. Okay, wonderful. All righty. Well, thank you, Dr. Kline, for educating us on how to talk with our doctors and answering questions from the audience.
More than welcome.
And a big thank you to our audience for taking some time out of your evening to join us here at CAW 360 Network. I'm Janelle Elgway, and with Dr. Kline, signing off until next Tuesday. Have a good night, everyone.
This has been The Doctor's Corner with Dr. Kline and Janelle Elgway. Copyright 2018. All rights reserved.